Tom, thanks. Did you get the water you needed?
Yeah, I got the water.
Did you look at mortality rates in those two groups where you're comparing similar populations in the same communities? And the N sizes were a little different. You know, one was 800 and something, one was 500 and something. But I think the analysis is good. But a sure endpoint is death.
Yeah.
Did you?
Well, we didn't. I mean, you're talking about a small sample to calculate death rates. You could look at census tract. Maybe if we pulled enough years, that we could maybe calculate a death rate. We haven't done that. But that's an interesting idea.
It's kind of a fixed gold standard.
Yeah. Yeah. It's a good suggestion.
You mentioned that a study that measured the percent of the population that is aware of health inequities.
Yeah.
What's the percentage?
Oh boy, I took those slides out. So I'm going to try to do this from memory, which is not always a good thing for me. But I remember HIV, like 17% of African Americans were aware of disparities in HIV, something like that. That was the one that really struck me. In no case was it above 50%. They asked about disparities across a variety of disease categories, and it was in no case was it over 50%. In many cases, less than 30%. I'm talking just knowing that there's a difference. Well, you guys are a lot easier than my round table. Boy, we work the speakers over. I think they're taking pity on me because I'm exhausted.
Very much appreciated your demythifying a lot of that. Yet oh yes, Jonathan Peck, Institute for Alternative Futures. One of the speculations this morning was around the role of stress and living, inside your skin in an environment where skin triggers a lot of reactions could be one of those factors that would be quite large and yet less large in the kinds of more integrated neighborhoods you said, or you looked at. Is that something you've considered at all?
Absolutely. I would say that the big S's, sugar, salt, sex, smog, and stress. That's what's killing people. That's what's driving these disparities. Sugar, salt, right, which is bad diet, sex, unsafe sex. Unsafe sex, no, good. Sex actually can mitigate the stress. At least that's what I tell my wife. But, sugar, salt, stress, smog, environmental differences, and stress. I think those are the drivers. That's what's producing the disparities. And if you live in a community where you experience violence on a regular basis, either directly or indirectly. And when that happens, you don't have an army of therapists descending on the community to provide counseling. So what do you do with that trauma? Where do you go with it? So much of the bad behavior that we see is probably untreated trauma that's driven by these experiences that people live under. So I think stress is ultimately the pathway through which a lot of these social determinants operate and produce the disparities in health behavior as well as in health outcomes. I think that the sugar, salt, and the sex is unsafe, irresponsible sex, is largely, I would say, a response to the untreated trauma and stress. So how do you deal with being, being grieved? We eat unhealthy foods. We engage in unhealthy behaviors that temporarily have an impact and make us feel better, but in the long term is harmful to our health.
Tom, thank you. It's been a great discussion. I can't help but ask, if you were to ask when the stress would have the greatest impact on a person's longer-term health outlook, would it be as an adult, as a teenager, as a kid, or a very young child?
I would say
for the same stress event.
Right. Oh, you're talking about an acute
Yes.
stressor. My suspicion is that the younger you are, probably the bigger the impact is going to be. But a lot of the stress we're talking about, I mean, I specifically talked about trauma, but a lot of it is chronic stress. Your body is chronically in a fight or flight state.
And for chronic stress, adult, adolescent, youth, or infant, chronic stress has the greatest effect at what age?
I think all ages, because if you look at virtually every cause of death, you see that African Americans and in some cases Latinos as well have higher rates at younger ages, earlier onset of disease, and that is probably because you are physiologically living under this under duress. So you get hypertension at age 35 when most people, maybe get it into their 40s or 50s, right? So I think it's happening at all ages, but of course the longer you live, the greater the likelihood that that stress is ultimately going to catch up with you.
Tom, you just were sitting here thinking about our report. You mentioned or alluded to limits in our national ability to understand things because of limits in the national data sets. I wonder if you could say a little more about if we were to have a set of recommendations about how to improve the quality of data that would
thank
help
you for that
us
question.
speak to these things more explicitly. If you could say a little bit more about what we might focus on.
Thank you for that question. So one of the other many hats that I wear, I am on the Board of Scientific Counselors at National Center for Health Statistics. So I've been pushing from that direction. But boy, if you guys can push from another direction, this would be helpful. We need data that collects income levels at much higher levels than just $75,000. That hasn't changed in, 30 or 40 years, and it's just ridiculous now to combine people making $80,000 with people making $200,000. It's a meaningless category. We need to extend that range much wider than that. The other thing is that we need better geographic indicators in the data. And I know that's complicated to do because of privacy issues, but we need to be able to distinguish where people live because we need to understand what those environmental conditions are. And it's important that we be able to link these national data sets like Health Interview Survey with census data, and the census data needs to continue to collect data at the census tract level, which is another issue. I would also say another thing that I would just be elated if you guys take it on to at least consider this, is the Census Bureau is now considering, and it's beginning to look like they are going to decide to do this, to measure race, instead of using the two questions that we currently use, where we first ask if you're of a Hispanic status, and then ask what your race is, which allows you to combine the two questions to get a category called Black Hispanic and other Hispanic subgroups. And they're talking about making that one question the way it used to be. Now, what that will do is basically make certain subgroups of the Hispanic population invisible. And I think, especially with the rapidly increasing Hispanic Latino population in this country, that is the complete opposite of where we need to go. Now, their argument for doing it is that increasingly people are responding yes to Hispanic, and then they say other, and the other category is growing. But I think there can be other more creative ways of solving that problem without causing us to not be able to get into the Hispanic subgroups. To take Cubans, Puerto Ricans, and Mexicans and put them into one category is that is really a group. It's not really a thing. If you just look at immigration policy and how it differs based on coming from those different countries. If you are from Mexico, you have presidential candidates talking about building walls to keep you out. If you're from Puerto Rico, you want to come into the mainland, you just simply get on a plane and fly into the country, fly here because you're already an American citizen. And if you're from Cuba, and if you can manage to get as far enough into international waters for the U.S. Coast Guard to pick you up, you are brought into the country and welcomed. It's not a group. This is a category of people who come from countries that were once colonized by Spain, and that status is not sufficiently important to to not analyze it as a single group. We need to be able to get into the subgroups to understand how different subcategories of the Latino population are experiencing life in this country.
I'm going to go. You have Can you use that mic there? Yep. And then Blaine, and then David.
I think this is less of a question and more of a comment for this academy to ponder. So one, my name is Wendy Purifoy. I'm a senior fellow at the Ford Foundation. And I'd like to thank everyone for all of the presentations today on social determinants, because it's been an amazing conversation and certainly a big aha moment to have everyone put their maps up and we see the environmental disasters and where they repeatedly occur. So we know that race in this country has manifested itself through the data that tell us that Black lives do not matter, that they can be put in harm's way consistently. And the only remedy for that is for them to become activated, as opposed to having the same remedy that whites have when people are considering where they will put the best goods in the best neighborhoods and the worst goods in the worst neighborhoods. So I guess my question is now, how do we construct a conversation informed by data, informed by the maps, that allow us now to take a much more conscious path about health and healthy development of the people who live in this country? The maps today were so convincing. How much longer are we going to continue with this farce? So that's my frustration, but that's my question.
Well, all I can say to that is, here. I share your frustration. I understand the frustration. I know where it comes from, and I get it. But I do want to bring somewhat of a hopeful, optimistic perspective to that as well.
Please do.
So it wasn't until the 1960s that African Americans were truly at least from a legal standpoint, full citizens in this country. And in that short period of time, we have progressed. We have made improvement. Many of us have been able to succeed in this society. Many of us have been able to change our lives and impact the lives of others. So if we take the long view, there has been some improvement. Now, has there been enough improvement? Absolutely not to my satisfaction, and obviously not to yours as well. But what that does tell me is that change is possible, that we do have the agency to make change, and that we can improve, that things can get better. It may not happen in my lifetime, I may not live to see it, but I think we all continue to fight to make that happen. But things have gotten better. Don't totally despair and give up in frustration. You have to just continue to keep the fight going. But we do have to know that we can make improvement and we can get better.
Hi, good afternoon. Dwayne Proctor, Robert Wood Johnson Foundation. Dr. Laveist, on the question of data, do you have an opinion on the need to disaggregate data beyond just the Latino populations? I noticed in one of your slides that American Indians weren't represented, and I'm certain that maybe some of the same issues exist with Asian American, Pacific Islanders, and others.
So Asian Americans, so 1/3 of the world population lives in either China or India, right? And when we put all of those people into one category called Asia, it's laughable. And then we further confound it by adding Koreans and other Asian populations. So the way that we measure race in this country is extremely problematic. Native Americans are often ignored simply because there isn't data. In many cases when I do presentations more broadly about health disparities and talking about a wide variety of groups, you simply can't include certain groups because there just isn't any data. And I understand from conversations with NCHS, there's a cost issue. It's very expensive to get good data on small populations. It's a complicated thing. But, you know, I think we do have technologies now that allow us to get some of those data, some of that data. I think even the black population, you know, we need to disaggregate that group as well. You have an increasing proportion of the black population who do not have ancestry coming through Middle Passage and slavery in this country. And those populations are likely to have some differences, and those differences need to be reviewed as well. So I think the data systems are not sufficient to really get at the complexity of what the American population is now. And unfortunately, what I see the Census Bureau doing is going in the wrong direction. Instead of getting more granular, they're going in the opposite direction and making it more difficult to really study the population.
So thank you. Sugar, salt, smog, unsafe sex, and stress. All right, so these are partly a function of environmental exposure, right? They're class inflected. You do your study, and you know, the purpose presumably is in part to control to some or account for environmental exposure to some degree, the best you can in a natural setting, and for class related issues, and still you have this residual difference. And yet we also know that those two census tracts are very unusual, right? So environmental exposure and class-related differences by race are part of what race is, right? Part of the way race has been experienced and constructed and all of that. So I end up with, you know, an uncertainty about the analytical story you're telling about race and the communication story you're telling about race, right? So could you say a little bit about what the takeaway is?
So the story is that when we think race, we often, in race disparities, we often start thinking about those three myths. And those myths all go back to an analysis that is individual level and sometimes even victim blaming. What I'm suggesting is that the issue isn't race per se from a health standpoint, the issue is place. Race causes place, right? So your race determines what kind of environment you're exposed to, but it's the environment that you're exposed to that's driving the health outcome. It's not something endemic to race that's producing the outcome. That's the message that I believe the study tells us. It's not endemic to the group. It's that the group is experiencing this country in a way that they have greater exposure to risks. And those risks is what we see reflected when we do those national statistics.
Can I ask one small follow-up? So, but you do have those residual differences, right? Even in that, right, much reduced but still significant?
Well, only hypertension showed that. But, so, you know, unfortunately, the social science is very complicated because the thing that we're studying, other humans, is just as intelligent as we are, right? And they have agency. So it's not like lab science where we can control everything. So we have two mice and we know everything about their genetic ancestry, and we can control the light and the humidity and the temperature and how much food they get, and then we can look at differences. Well, with humans, people have behaviors, people have agency. So they may live in that community, but people do move. Some people maybe didn't live in that community their entire life. Others may have jobs outside of the community. So there is some variation that we can't capture. And the goal was to do a study of social determinants. Typically what we try to do is to measure all the social determinants and see how those determinants impact health outcomes. But there are too many and it's too complex to do that. So the idea that we had was, what if we can make the social determinants a constant rather than making it a variable? So all of that stuff that we don't even know what we should be measuring, nor do we necessarily know how to measure it, we don't have to measure it because they're all living in the same community with the same exposures. So whatever those exposures are, it's affecting everyone. The disparities were eliminated in the vast majority, all except for one case, the disparities were eliminated. And they weren't eliminated because the black population was healthier. They were eliminated because the white population was sicker. And their health outcomes looked just like African Americans that live in low-income urban communities, because anyone living in that community is going to have bad health outcomes, and being white doesn't protect you from it. And that's what we learn when we see a white population living in a community like that.
Thank you, Tom.
Thank you.
And welcome to this area, GW. Thank you.